Everybody, welcome to Heat Stroke, the Case from Hell. We're going to dive into a case study. This case study is fairly old, but I think it highlights just the severity of this disease process. We're going to go through all the different types of heat-related illness and touch on this case throughout and focus on the overall resuscitation. Objectives, as always, we're going to look at the specific case study. We're going to identify assessment pearls within heat-related illness. We're going to break down the pathophysiology and how our body responds to heat stroke. To do that, though, we have to look at the physiology. How does the hypothalamus work? What areas of our body does it interact with to allow for proper regulation? We're going to analyze core resuscitation in these very difficult to treat patients. The case from hell. Oftentimes we are our worst enemy. We have no idea that we're getting into trouble until it's too late. Many of you listening may already know you're more susceptible. You don't handle the heat as well as maybe other friends or family. But I think it's super easy to get into a situation where you move into a heat exhaustion, and we're always of the mindset, I know I am, where I always think I'm stronger or that I can withstand more than I should. Now, I've never been in a heat-related illness state. I definitely have got to a state where I feel like I was definitely overheated, but I tend to be able to regulate pretty well. Ashley, on the other hand, does not handle that heat regulation side very well, and it's very easy for her to get into a situation where she is in trouble. Based on that, we have a 38-year-old male. Patient was hiking with friends and family. Very hot, humid day. After the hike, showed exhaustion, actually had a flat affect, and was really showing that apathetic demeanor. Family and friends stated that he normally is very outgoing, always the jokester, so he was very quiet, and that definitely worried them. So they did call 911. Ambulance was about 45 minutes to 60 minutes away, so they opted to go by private vehicle. They arrived at the ED. Patient, shortly after arrival, went into a grand mal seizure, lasted about a minute. Glasgow Coma Scale after the seizure in that post-ictal state was around 6. Did progress pretty rapidly into respiratory and cardiovascular collapse. Patient was intubated by the ED physician, and there was a first pass success. Blood pressure initially, once the seizure stopped, 60/20, heart rate of 166, and a temp rectally of 40 degrees Celsius. So let's unwrap that. We have a patient that is already seized. We have a patient that has a decreased mentation, has that central nervous system impairment, has progressed to respiratory arrest, cardiovascular collapse, definitely has a critically low blood pressure with a map that is very, very terrible. Heart rate 166 and has that core temp that is at the level of heat stroke. The blood pressure for a patient of this age is obviously critical. We know that this patient is likely volume depleted, and we can lose up to 3 liters an hour in that hot, humid environment. The heart rate, though, I want to unwrap, and it's super easy, and I ask this to every class we teach when we're going through cardiology and advanced hemodynamics. You know, you give a patient with a narrow complex QRS a rate over 150, and automatically we think this is SVT. We have to be very careful to have that mindset. Even though a lot of times ACLS guides us down that pathway, we have to also recognize that sinus tach is considered anything over 100 up to 220 minus your age. And so we have to always step back and think about resuscitation points. What's going to cause a patient to become tachycardic? Well, are they hypoxic? Are they hypovolemic? Are they hyperthermic? So the 3 H's, I always say, rule in or out the 3 H's before you ever go down the pathway of SVT. And this patient checks 2 of those boxes. Patient is hypovolemic and the patient is hyperthermic. So I would say that that is pointing to why he is tachycardic. The patient progressed to ICU admission very rapidly. Hospital was very quick to move the patient to the ICU. Cardiac instability continued. They did give him a total of 3 liters of normal saline without really any significant change. Blood pressure came up a little bit, but we still had a very poor perfusing map, so they opted to go norepinephrine. They started at 5 mics per minute. Labs came back. All of the liver enzyme tests were impaired. PT was lengthened at 60%. Notice BUN and creatinine are elevated significantly to the acute renal failure levels. And we have a CK of 95.1 or 95,000, and we have a myoglobin of 19,000. So those are extremely significant. And that's where we're really going to focus. Obviously, acute renal failure in this patient is something that we have to address. It's nothing that I would say is out of the norm for his presentation or any patient like this. You should automatically suspect based on volume depletion that that's going to happen. But when you start thinking about the CK, the myoglobin, those levels being that elevated, that is the recipe for rhabdomyolysis. And so even though the patient might not be showing any signs of that outwardly through urine output, I would say the urine output in this patient is almost non-existent. And so they got to get this patient peeing. They got to get the volume replaced. But a normal CK level is only 38 to 174. This lab is 95,000. The myoglobin norm is 0 to about 116, and his myoglobin level is 19,243. So these are both significantly elevated. Why is that important? Well, when you think specifically of myoglobin, myoglobin is not something that we want released out of the muscle. Myoglobin is important to transport oxygen within the muscles, but we know when that gets pushed out of the muscles and gets into the bloodstream where it gets and moves into the kidneys, it is very, very toxic. And so that's what's going to potentially cause that chronic renal failure to where this patient is in a acute to chronic kidney injury state. Based on that, let's look at and really from a global perspective, look at the physiology. How does our body regulate temperature? Well, we know it all starts within the brain, and it starts deep in the brain in the hypothalamus. And we know the hypothalamus is what regulates the different areas of our body and really is the message center that sends messages out to these areas if we're hot or if we're cold. So it does that in a few ways. It is going to vasodilate smooth muscle. It's going to allow us to sweat, right? It opens those pores and allows us to sweat and starts that stimulation. It lays down our hair follicles. It then can vasodilate and change the vascular size within our skeletal muscle. And lastly, it triggers adrenal and thyroid gland stimulation that is going to regulate metabolism. And so whether we're hot or cold, we know that these are either going to be more of a vasoconstrictive in context of, our vessels, our skin, our skeletal muscle. It's going to increase metabolism in a cold state. It's going to decrease metabolism in a hot state, right? So it's constantly fluctuating and triggering all these different areas of our body. So when our patient starts having an increase in that temperature, obviously we vasodilate. That sweating starts. We all have experienced this. Sweating is important because it allows us to release that fluid across our body, and then we have the wind and the air that is cooling us by moving across that wet skin. Hair follicles flatten, or hair flattens. And then we know just kind of that last line of defense, our respiratory rate will increase, and that allows us to get rid of and dissipate a lot of heat. And that's why any of our animals, specifically dogs, you see them panting, and that's a great way for them to constantly get rid of that heat production. So if we look at this patient again from really all stages of heat-related illness, he, she, you and I, we start normal, right? How we enter into an exertional state or an environment that is hot and humid, are we already hydrated? Are we behind on our fluids? Are we drinking alcohol and not bringing in normal volumes of water or Gatorade, Pedialyte, Powerade? That's going to really determine how we handle that environment. But it all starts with heat cramps. Heat cramps, if not addressed, will move eventually to exhaustion. And I would say that not every patient is going to have true heat cramps or have muscle spasms. They may progress through the heat cramp stage to an exhaustive stage pretty rapidly. And then lastly, we have that heat stroke. So if we break these down specifically and individually, we know that heat cramps are a state where our body temperature really is not changed. We often will have muscle spasms. We're going to have those cramps. That's lactate production in our muscles. We're not hydrating as well as we should. Our skin is flushed, right? We're able to vasodilate. Skin follicles can lay down. Our skin is moist. We can sweat, but we're starting to maybe get a little behind the curve. And so when we think about how do we treat that, well, we reverse how this all started. We got to get out of that environment. We got to remove any excess clothing. We got to start allowing ourselves to rest, start hydrating, oftentimes just drinking fluids, cold fluids, sitting down, laying down, whether that's water or Gatorade. But hydrating is going to be the key. And most of the time, we do really well by just taking ourselves out of that situation and starting from scratch. If we progress to the exhaustive state, the heat exhaustion state, that's where our temperature, our core temp, can increase over 100 degrees Celsius. So that's the classification, that temperature level. And that's a corresponding 38.6 degrees Celsius temp. Definitely going to have heat cramps. We're going to have the spasms. A lot of times these patients are going to have nausea, associated vomiting. They're going to be fatigued. They might have a syncopal episode. It might precipitate to where they're noticed by a syncopal episode or a fainting spell. That might be more pallor, more pale in appearance, but they're still going to be able to sweat. They're going to have that moist diaphoretic appearance to them. And no different than heat cramps. We got to remove them from the environment. If you feel like you're in this state, remove yourself from that environment. Remove any excess clothing. Start hydration. A lot of these patients are going to be pretty tachypnic that I have found. So humidified oxygen, high flow, IV fluids. I would do 2 large bore IVs and start getting cold, normal saline flowing through. And obviously we want to check that glucose and treat that glucose if it's low. Again, a lot of times from my experience, these patients are very treatable, but I've had a few patients that have been right at the cusp where very easy, if they wouldn't have removed themselves or it wouldn't have been noticed, would have progressed to that heat stroke stage. And I have found these patients to be very sick. They definitely feel pretty bad in those situations. And then we find our patient in the last stage, and that is a heat stroke stage. Temp, again, classification, if you're taking an exam, is anything greater than 104, which correlates to a 40 degrees Celsius temp. Their skin is going to be now hot and dry. They're not going to have any outward sweating. They lose the ability to sweat. They're probably going to have an altered mentation. So that central nervous system is going to be depressed. A lot of times they're going to progress pretty rapidly to seizure activity. They're going to have respiratory and cardiovascular collapse. And I would always say to look at these patients from the standpoint of they're probably going to end up in some form of rhabdo. Checking those labs, especially if they've exerted themselves and that's what has precipitated this decline, are they going to have specifically a CK myoglobin level that is high? And I would say most often that is the case. And if that's not addressed and if it's not worked out from a resuscitation standpoint, then they definitely can move into more of an acute kidney injury. But I would always say that these patients are going to be in acute renal failure simply based on volume depletion. No different. We're going to remove them from the environment. We're going to remove all their clothing. This is the type of patient, and you could also say this for heat exhaustion in some cases, remove the clothing, put them in a modest environment, put a sheet over the top of them, start cooling down that sheet with cold water. We want to get their temperature in a heat stroke patient down to 102 as quickly as possible. There's no specific criteria that says, hey, to a point of that 104 threshold or 40 degrees Celsius down to 102 that it's got to be in a specific rate. We want to rapidly bring it down to 102. And then from there, we can slowly, incrementally bring it down lower and lower. And we'll talk about that as we progress through the case. Obviously, large bar IVs get that volume going and continue to check the glucose. This is just the initial thought process. Obviously, place them on a cardiac monitor, address any airway situations, think about being proactive, not reactive. And so really from the resuscitation standpoint, long term, and from a global perspective, right, these patients are most likely going to be nauseated. They likely will vomit, so don't be afraid to give them something for that. Altered mentation, can they protect their airway? Remember, assessing airway and a patient's ability to maintain their airway is not about the Glasgow Coma Scale or an altered mentation. It's, can they control their secretions? Can they follow your commands? And what is their overall clinical course? How are they going to progress? And that's where we always say be proactive, not reactive. If they progress to respiratory arrest, obviously you have to treat this airway from an advanced airway standpoint. I would challenge each provider to try to be a little bit ahead of the game. I know it's not always possible, but you don't want to get into a situation where you are reacting to a situation where maybe you are not making decisions like you otherwise would. And I think airway management is one of those areas where we want to always be ahead. We want to control the situation as much as possible. A lot of these patients are going to have electrolyte imbalances. They are likely based on the free water loss. Many of them may have a hyponatremia. Some may not, but think about the seizure activity from that standpoint. Could this be based on a hyponatremic state? Does the patient have a perfusing map? Are they in a hemodynamic instability that you need to be aggressive? Ultimately, we can intubate our patient. We can put them on a mechanical ventilator. We can manage their airway. But remember the two factors that drive O2 delivery: the content of arterial oxygen and ultimately our cardiac output, right? Got to have the motor that drives and pushes all of that oxygen-rich blood. And so we got to be diligent. We got to remember these patients. As I said, they're likely going to lose up to 3 liters every hour. They're going to be definitely behind, but we have to be very careful not to give too much. We don't want to overload them with fluid either. So think about early vasopressor support. As I said, always suspect rhabdo. That's going to be more of an ongoing resuscitation factor to watch those labs, get those initial labs, see what that CK and myoglobin levels are. The renal failure. The renal failure is going to be an important aspect. That's, again, going to be more long-term. And so from the standpoint of treatment, we're going to talk about what our urine output goals are going to need to be and how we look at that from a long-term standpoint. So progressing to more of a resuscitation from the cooling standpoint, one of the things they did with this patient, and it's highlighted in the case, is they definitely employed a cooling blanket. But one of the areas that they really talked about is they had an inability, even after 8 hours, to bring the core temperature down. And again, the goal is to get that core temperature down pretty immediate to less than 38 degrees Celsius. And that really, from a per minute standpoint, is 0.25 to 0.35 degrees Celsius every minute. They were unsuccessful utilizing this technology. So I think that is the key, is what is your backup plan? Got to get that core temp down. We know that is key. What would you do in that situation after 8 hours? Is there something that is available to you that can give you a greater ability to bring that temperature down? From an ongoing assessment standpoint and looking specifically at his case, we know that the blanket cooling was not working. So they opted to move to an intravascular cooling system where they did a subclavian, I believe left subclavian cannulation. They had real-time reporting of temperature in the bladder through that Foley. And it was all about volume, and optimizing that output with diuresis. Now, again, we talked about rhabdo. We talked about the high probability of rhabdo. And as you can see, that initial CK and myoglobin level was, remember, CK was 95,000, myoglobin was 19,000. And so when you think about 7, 8 hours later, they have core temp down to 37.5, but CK level is up to 102,000. Myoglobin is up to 32,000. So pretty significant increase in myoglobin. Not a huge jump in CK, but both of them very, very significant. So that intravascular network, again, left subclavian axis, target temperature was 37.5. And their goal was to cool the patient at about a half degree Celsius every hour. They did this over 111 hours. So it's quite a long time to get that temp down. Their focus really was the rhabdo. They were really, really focused on trying to alleviate any potential kidney injury long term. And so, as I said, fluid. Got to maximize the urine output. But I don't think I had a real sense of how much urine output we're looking for. We know diuresis can be done in a few ways. They opted to go Lasix into him, but we know we can use mannitol. I think Lasix is much easier to use. But their target urine output was 400 mils per hour. So think about that, 400 mils per hour. Our normal patient is 30 to 50 mils per hour. Burn patients in rhabdo, we want about 100 mils per hour. So they were going 400 mils per hour as a goal for this patient. So that's a lot of urine output. When you now couple rhabdo with acute kidney injury, or the thought process of acute kidney injury, and that really was where they were going. Obviously, you want to keep pushing those fluids. You want to maximize diuresis. If the patient is not on any Lasix for any underlying disease of the heart, then a 10 to 20 milligram dose is appropriate. But you also have to make the decision on any hemodialysis. They opted to go with a target urine output because they were so worried about acute kidney injury at 50 mils per kilo per hour. So think about that and do the math. If we have an 80 kilo patient, which is a very average male, that's 4,000 mils an hour of urine output, 4,000. So 4 liters of urine output an hour. So that's a huge, huge amount of urine output. And it's all about trying to flood the system and put volume in and get volume out. We want to wash that myoglobin out. We don't want the myoglobin sitting in those distal tubules. We don't want it to become, toxic. It basically just tears up that area, and that leads to long-term kidney damage, where a lot of these patients end up being on dialysis or having to have kidney transplants. One of the things that I haven't really addressed is in mainstream teaching, we always think, hey, sodium bicarb in a rhabdo patient. And I think what I have seen in burn patients as well is if your patient has any fluid overload or any disease process where they can't pee normally, right? They have a deficient kidney already. They're in a later stage CHF and they just can't handle the volume. That would be the time to alkalinize the urine and try to keep that urine pH greater than 6.5. But other than that, it's going to be more of a physician-provider decision on if they want to start sodium bicarb. And again, from what I'm seeing, that is not an automatic treatment. The case summation is really, not terrible, right? Patient was extubated on day 8, was moved to a neuro ICU and discharged on day 12 without any deficits in normal labs, and actually did very, very well. So I think this is it's a quick lecture. It really highlights different aspects of resuscitation from the pre-hospital side to the hospital side. Obviously, there are a lot of elements within this case that we could dive into, but I think from the airway side, the hemodynamic side, those are all resuscitation areas that we should be comfortable with. We're going to treat those as they come. We just have to remember that heat-related illnesses are a true medical emergency. We need to keep that in the forefront. Have a high index of suspicion. Remove the patient from the environment and get them in a situation where they're, covered up, that you can keep them modest, get their clothing removed, and move to active cooling measures. If you're in an ambulance, start that air conditioner, get them in a state where you can put a sheet over them, start cooling them with cool normal saline over the sheet. That air conditioner will blow over the top. Core temperature reduction down to 38 degrees Celsius in the immediate time frame of resuscitation, and then thinking about, hey, what am I going to have to do in 10 minutes, 20 minutes from the airway and cardiovascular standpoint? We often focus on temperature reduction. We have to also remember that we really need to be doing rectal temperatures. We have to get an accurate representation of where the core temp really is. Rhabdo, an acute kidney injury, is a common manifestation of heat-related illness. We need to automatically start the volume, but I would say don't get aggressive. 2 or 3 liters max is going to be more than enough, and it's going to depend on your transport time. In that acute kidney injury situation, when you're thinking about more of a long-term, you're in a critical care setting where maybe you're transferring these patients, you have a confirmed high CK, high myoglobin. Acute kidney injury is definitely one of those mindsets. Then 50 mils per kilo per hour is a realistic goal. But think about that is a lot of urine output. And so do you have the means to manage that much volume out? The last thing is really the NSAIDs. And I didn't really talk about it within the case because I didn't want to confuse anybody. But as I said, this case is very old, 2005. I thought it represented heat stroke very well. But long gone are the days of treating any heat-related illness with any NSAIDs, so aspirin or Tylenol. Really, there's no evidence, there's no indication, and actually they've shown that it could be a poor treatment choice in these patients. As always, if you have any questions, don't hesitate to email me, eric.bauer@FlightBridgeED.com. I look forward to the questions, and if you have any ideas for further webinar topics or cases, again, email me those, and we will talk to you soon.